From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today, we're thrilled to be discussing a new paper just out in JAMA Psychiatry, GLP-1 Receptor Agonists, Mortality and Cardiovascular Outcomes in Serious Mental Illness. We're about to speak with Professor Roger McIntyre, MD, with the Department of Psychiatry and Department of Pharmacology and Toxicology at the University of Toronto, as well as the Brain and Cognition Discovery Foundation in Toronto, Ontario, Canada. People with serious mental illness die on average 10 to 25 years earlier than the general population. Cardiovascular disease is the single largest driver of that gap, but for decades it has stubbornly persisted. What if a new class of medications developed for diabetes and obesity, of course the GLP-1 agonists are always in the news and even covered on prior podcasts here, could actually help? To find out, we're about to speak with the corresponding author of a new study just published in JAMA Psychiatry that examines outcomes of more than 1.5 million people. So thank you for joining us, Dr. McIntyre. And to jump in, let's set the stage. We know that serious mental illness, we'll define it here as major depression, bipolar, and schizophrenia. People with serious mental illness die earlier than the general population. Can you walk us through the scale of the mortality gap and why cardiovascular disease is center stage here?
John, great to do this podcast with you. You really started off so nicely. You set the stage so beautifully and articulately. Absolutely, it's the case. We have replicated evidence now across different countries, different parts of the world, that living with a serious mental illness, such as schizophrenia, bipolar disorder, there's others, of course, is associated not only with an elevated mortality, but a younger age at mortality. In other words, potential years of life lost is very, very high. Just to put a number on this, depends on the study, depends on when it's been reported, but in the range of 10 to 20 years, sometimes a bit higher, sometimes a bit lower. This is the years of life lost with mental disorder. And cardiovascular disease is the single cause that's the largest contributor. Now, if I step back to think about what would be driving the elevated cardiovascular risk, I think I would have to start with aspects of social and economic determinants. Of course, many aspects about our patients with respect to insecurity of housing, healthcare, finance, and of course, just having a roof over their head. These are all important aspects. But at the neurobiologic level, there's been a confluence of evidence that has really, in fact, come together the last decade and a half, indicating that this population has risk factors in addition to the traditional risk factors of elevated rates of smoking, elevated rates of type 2 diabetes and obesity. When we actually look into the biology of the condition, we also witness that these individuals are more likely to evince what we call pro-inflammatory balance, metabolic disruption, as well as vascular pathology. So we no longer think about schizophrenia, bipolar, these other conditions simply as a disease of the brain. They are a disease of the brain, but they're also multi-organ involved in these neurobiologic systems intersecting with social economic determinants creates this awful situation.
You can see why there's so much stacked up against our patients trying to do well and thrive with this. And so clearly GLP-1 receptor agonists are drugs that seem to be in the news almost every day.
Yeah, true.
What are they and what do we know about their effects on mortality and cardiovascular, let's say in people with diabetes? We'll get to serious mental illness next, but let's set the stage for what are these new medications and how well do they work?
Yeah, you're absolutely right. I mean, I think GLP-1 receptor agonists, which are the pharmaceuticals that mimic the effect of the endogenous or native GLP-1 protein that we produce, have become almost a household name. I mean, my goodness, everyone's talking about it. It really is, in fact, the case, and without any hyperbole or superlative, that the GLP-1s have transformed. The word transformed has been perhaps overused. They have transformed obesity and type 2 diabetes management, and that is a fact with respect to the impact on these conditions. You know, it's interesting, John, just a bit of a historical footnote. We work in psychiatry, you and I, and the GLP-1s in many ways go back to good old Ivan Pavlov, classical conditioning, looking at salivating dogs. The history of trying to better understand aspects about endocrinology and psychiatry almost kind of marched lockstep the last 100 years. In fact, it was the pursuit of what was actually driving pancreatic secretions that Dr. Pavlov was very much instrumental in, that actually led to the serendipitous discovery of what was called then secretins, which was then changed to incretins. The GLP-1, it's a very interesting historical footnote. So in some ways, psychiatry has its DNA on the discovery, so to speak, of the incretin system in some respects. So this is not totally out of our wheelhouse. And the very first of these proteins, again, was discovered back in 1902. And just to keep it brief, the challenge we've always had with GLP-1 as a protein, we've known for a long time it's an incretin. What's an incretin? An incretin is a protein that enhances insulin release in response to an oral glucose load. It also reduces glucagon. The net is it enhances glucose-insulin homeostatic control and consequently reduces weight. Now, we've known this for a long time, but it was tricky to actually mimic physiologic GLP-1 because it has a very short half-life, maybe 1 to 2 minutes. And through a series of incredibly interesting stories involving lizards and Gila monsters and all kinds of things, it was discovered that there was a mechanism wherein you could provide a pharmaceutical, which is a synthetic mimic of the GLP-1 natural ligand, that could last longer in the system. The first GLP-1, John, as you know, came out in 2005. The FDA approved it. The year following, 2006, the protein that breaks down GLP-1, which is DPP-4, a DPP-4 inhibitor was then FDA approved. And then I have over half a dozen of these treatments. They're very different. They came ashore initially to help people with diabetes mellitus. That then expanded into weight loss and people who are overweight, obese. And now we have a total of 6 FDA indications as a class for these drugs, each agent slightly different. And I think what it has ignited is not only interest in other disease states, for example, psychiatry, but also it's really, in fact, ignited a whole set of research endeavors trying to better understand how they work. And they certainly work in the brain and the periphery. And interestingly, John, they target some of these key effectors that are implicated in conditions like cardiovascular disease, like inflammation, metabolic disruption, and endothelial dysfunction.
There have been a couple recent randomized trials looking at, say, semaglutide in people on antipsychotics. What did these trials briefly show, or what do we know about those early studies in people on antipsychotics?
That's right. So practitioners of psychiatry know that too often our medications do cause problematic weight gain and associated morbidity like hyperglycemia. And I think we all learned as students and as young clinicians in our career that if you have a drug that's offending the patient in some way, well, just stop it. Try something else, especially when it relates to weight increase. Well, that's not an option for many patients, especially many of our difficult to treat situations where you have a patient who might need clozapine, as an example, to help them with schizophrenia. And we know that clozapine can be a very effective drug, but significant weight gain metabolic problem. There's 3, as you mentioned, randomized controlled trials, very rigorous randomized controlled trials, very carefully done, thoughtful academic studies, well-designed, very, very, very clear in terms of the methodology, replicated evidence showing that GLP-1s significantly reduce weight caused by the drug itself, but also the illness, because part of this is the drug, part of this is the illness, and also improving metabolic parameters. So we start off by saying GLP-1s already are fit for purpose. They're evidence-based in the sense that they're FDA approved for 6 conditions that differentially affect people with serious mental illness. In addition, we have now replicated rigorous evidence that they can help mitigate psychotropic drug weight gain, which actually is opening up a whole new vista for us, John. And this is the aspiration. If these drugs are so good at treating weight and difficulties with diabetes, can they actually help brain diseases? Can they directly treat mental illness like alcohol, substance use, or schizophrenia or bipolar? And this is actually, as you know, a very hot topic right now.
To jump to your study design, you and the team used something called target trial emulation. What is that, and why did you choose it rather than, say, a standard observational analysis?
Correct. Let me begin with what it is not. I like to always define sometimes an entity by what it is not. It's not a randomized controlled trial in the traditional sense. In other words, we know what a randomized controlled trial is. We take a sample, we randomly assign a group to the intervention, the other group, say, to placebo. Everyone's blinded, you have an endpoint, you have measures, so on and so forth. That would be considered the apex, the highest level of evidence according to a regulator like the FDA. An observational study is also something slightly different. You just look at data. You look at, say, 1,000 or 10,000 or 100,000 people. In this case, let's say people with schizophrenia are taking a GLP-1 for a year or 3 years. What happens to these people after 1 to 3? You're just observing what's there just organically. You're not controlling any variable. There's strengths and weaknesses to each of these approaches. We chose a target trial emulation design. What is it? Well, it's sort of in the middle. A target trial emulation, what we're trying to do is emulate a controlled study. Why we are, I say, permitted to do this is because we have a very large sample size. So what we did was we went into a database that contained, frankly, over 150 million in total. This was all people with mental illness. And we're able to find in this data set a large number of people who have mental illness. In fact, over 1.5 million people. So we start off just by stopping for a second. That's a lot of people. 1.5 million.
That's a very big
right?
number for any study, especially a study of serious mental illness. This is huge.
Exactly. I mean, John, I've spent 30 years of my career, more than that, 35 years doing research in psychiatry. If I can get 20 patients into a study, I'm happy. 40 patients into a study, I'm happy. This is 1.5 million people. So this is enormous. Now, what we make up in perspective, in volume, we do lose in a bit of precision. This is not controlled. So what we do is we go in there and we find out, okay, who in the database has, for example, schizophrenia and bipolar? Who has major depression? That's exactly what we did. We call that serious mental illness. And then we find out, okay, who took a GLP-1 and who took a drug other than a GLP-1 to treat a condition like diabetes. We conduct what's called propensity score matching. John, I can say this as two academics. We in academia use too much language that's too opaque. All propensity score matching means is we're just trying to match people on as many variables as we can. So if you're going to test a hypothesis that a GLP-1 could potentially benefit aspects of mortality, you want to match the participants on things like age and sex and other aspects about their illness. Correct. So that's the premise of a randomized controlled trial. You want to balance these factors out. So propensity score matching is just academic language to say we're trying to match everyone on as many variables, 40 plus to be exact, so that the two samples, for all sakes and purposes, look similar so that our findings are valid and not confounded by some type of residual factor. So it's a rigorous, virtual, so to speak, controlled trial comparing two parallel groups, well-defined, well-characterized, and well-differentiated.
Another interesting design that you have is you compare people on the GLP-1 receptor agonists, the drugs we're talking about, against SGLT2 inhibitors instead of no treatment. How does that make the study stronger?
Correct. And just we're paying, because this is a lot of alphanumeric soup here. What do these initials even mean? So GLP-1RAs, of course, are the Glucagon-Like Peptide 1 receptor agonists. For those maybe a little less familiar, SGLT2 inhibitors is a separate class of drugs that are approved for diabetes. So if our proposition is that GLP-1RAs have mortality-lowering effects in the seriously mentally ill, it would make good sense to compare it to a group of drugs that are already well known to have beneficial effects on diabetes. Because people typically prescribe GLP-1s for diabetes. Because if I, in fact, take, let's say, a group of people with schizophrenia or bipolar depression, I put them on a GLP-1 and I reduce mortality, many people would say, I'm not surprised because they're really, really good for obesity and they're good for diabetes. That's the full story. But if, in fact, you compare it to a well-matched other group taking other diabetes drugs or drugs that can help weight loss, either or both, and your result is still in favor of the GLP-1RA, you would then be safe in assuming there must be something else going on here. And that's why we did it this way.
And it's just fantastic because, again, having this type of control group, we can answer a very specific question that we just don't know yet.
Correct.
So let's talk about what are the primary and key secondary endpoints going to be, and why did you choose 4-year all-cause mortality as one of the primary endpoints?
Yeah, part of this is personal and part of this is professional. Personally, when I came into psychiatry, I came into the mood disorder era, I always thought to myself, I would love to figure out a way to reduce mortality in this population. We've got potential years of life loss that's unacceptable. People are often losing their life in their 50s. We've got to do better. So given what we know, that GLP-1s already have an FDA approval in the general population, in people who are eligible to reduce mortality in people who have conditions like obesity and related metabolic problems, we said, why don't we go with, this will be the very first study to look at mortality reduction, all-cause mortality reduction. We want a bit of a runway. We chose 4 years, but we also chose 4 years because many of these GLP-1s, they didn't all become available on the same day. They've been sort of becoming available over the last 10, 20 years plus. And so we wanted to have an adequate window of time where people get adequate exposure to the different drugs that have come online at different time points. So we wanted an adequate timeline to believe that there's adequate exposure and also sufficient timeline to allow entry of the different agents. Some of the newer ones like tirzepatide, that was only just a few years ago, so we wanted a bit more time for that one to get on board. But we need in psychiatry, John, you know this, the strategic imperative in psychiatry is to reduce mortality. And it starts with, why don't you reduce mortality from the most common causes like cardiovascular?
There's so many exciting results in the paper. I encourage everyone listening to read the paper, but let's go to one of the headline results. Among people with serious mental illness, what did you find for this 4-year all-cause mortality with GLP-1 receptor agonists?
What we did find, which was really, really thrilling, and to be quite frank, I'm really thrilled by this personally and professionally, we did find that the mortality amongst our definition of SMI, serious mental illness, bipolar, schizophrenia, MDD, was significantly reduced in the population receiving GLP-1 RAs when compared to those receiving the alternative, that being the DPP-4. Now, when we talk about the reduction, well, what was the reduction? Well, the reduction was a relative reduction of about 24%. Our hazard ratio was 7.6. That's a 24% reduction. And that is enormous. And that finding, John, also extended into some of the secondary outcomes that we had. So the primary outcome was the 4-year mortality. That was what we were most interested in, a 24% risk reduction. On the secondary, John, we looked at 1-year mortality reduction, and we also saw mortality reduction that was greater than the SGLT2s, which gave us reason to believe mechanistically, this is a hypothesis, that the mortality reduction cannot be explained alone by weight reduction in diabetes. We would not expect that to have that signal so early. Third point about this, John, we had what's called the 3-point MACE and the 5-point MACE. For those less, we're doing too many acronyms. MACE is major adverse cardiovascular events. And this is an outcome often used in cardiometabolic research. The 3-point MACE is a composite of cerebral vascular disease, cardiovascular disease, and death due to cardiovascular disease. The 5-point MACE is the same, with the additional 2 points being ejection fraction failure, heart failure, as well as revascularization, such as bypass, need, or stents. And what was interesting, John, in addition to meeting our pre-specified primary, that being reduction all cause in the 4-year mortality, on the secondary, yes, there was mortality reduction all cause at 1 year, but we also saw, John, reduction on the 5-point MACE and the 3-point MACE. So this is the first time that I'm aware of in psychiatry that we've seen any signal, anything like this, vis-a-vis reducing mortality writ large, but also for the most common causes, that being cardiovascular related.
I mean, these are huge effect sizes for psychiatry, as we know too. We work hard to help patients, but to get a 24% reduction like that is just unheard of for so many interventions, it really is amazing. And again, the size of your study, right? We're talking about 1.5 million people. This is not a small cohort.
Exactly.
And of course, serious mental illness, as you defined it, it can include schizophrenia, bipolar disorder, depression. Were there any differences you saw across kind of different illnesses inside this umbrella term?
Such a critical question, and you're right. I don't think any one of us believe that these three conditions are identical, and we did. We found something. Again, it's a bit of an exploratory finding. It wasn't the primary question because we looked at the population as a composite. But here's the part which was interesting. So we saw that risk reduction for the population writ large that we talked about, the 24% risk reduction. Of the three conditions, MDD, major depressive disorder, bipolar disorder, and schizophrenia, the risk reduction in major depression was 45%. Bipolar disorder was a close second at about 43%, and schizophrenia was a close third, really at 33%. So there was a suggestion, at least, again, this is very suggestive, by no means is this confirmatory, that there was perhaps even a greater effect seen in those receiving these treatments who had MDD, albeit the effect in bipolar disorder, 43% risk reduction, and schizophrenia, 33% risk reduction, was obviously very, very significant. The other part that caught my eye, John, which is really interesting, again, highly exploratory, sometimes 1 + 1 can equal 3. And what I mean by the metaphor is what we did find in a separate exploratory analysis is that when GLP-1s were combined with SGLT2s, there may be additional benefit, but that's very speculative. But to stay closer to what our primary focus was, we did see differential risk reduction across the three groups, but that's very preliminary, but very exciting.
For clinicians listening and caring for people with serious mental illness, what do you think is the best way they can apply these findings today, and what does responsible integration of these GLP-1 receptor agonists into care look like?
Absolutely. The way I think about it, John, is three ways. In a previous podcast you had on JAMA, you talked about repurposing GLP-1s to primarily treat psychiatric disorders. That's the future. Fingers crossed, one day we'll get there. I'll call that the aspirational category.
Okay.
Secondly, what I'm going to call the evidence-based category has two separate compartments. Compartment one would be, what are the current FDA-approved indications? Each of the 6 FDA-approved indications across the GLP-1s as a class, each one's different, those conditions are already overrepresented in our patients with mental illness. Secondly, right? So those 6 conditions are obesity, diabetes, metabolic liver, obstructive sleep apnea, progressive kidney disease, and diabetics, and cardiovascular disease in people with obesity. Then if we go to what you and I started off with, it is evidence-based to use these treatments sort of off-label, but sort of on-label to mitigate psychotropic drug weight gain. Now, answering your question, I have now arrived at the conclusion, and these results are obviously very exciting, and of course, forget to mention, we want to see a large randomized controlled study, but it's difficult to do studies of this magnitude from a feasibility perspective. So for me, I actually now believe, and I have these conversations with colleagues around the world, I think that when you are training as a mental health care provider, you learn about lithium, you learn about SSRIs, you learn about the standard treatments for our clozapine, you learn about cognitive therapy and all the neuromodulatory approaches. For me, I no longer can imagine how it's possible that a mental health care provider cannot be versed in some way on GLP-1s. I think they are now going to become integral to helping our patients, if not only to treat their existing comorbidity, which is on label, but if these data can be replicated, if these data are epistemically accurate, which I think they are, which means are they truly accurate? I think they are, because we see this in the general population with these drugs, that they lower mortality. So this is not some type of finding that's far reached, removed from what we already know from these drugs. I think it's transformative, John. I really do. I think it's potentially transformative if we can have a treatment that can not only prolong the lifespan of our patients, but also help the health span. And just recently in Lancet, the Global Burden of Disease study published their updated estimate of the disability-adjusted life years. And in many ways, what I can say is the strategic priority of psychiatry is to prolong the health span and the lifespan of our patients. And GLP-1s are helping us in both of these ways that we've never seen before.
It really does seem like a paradigm shift in progress, and this evidence only kind of helps progress that forward. That's all the time we have. Again, I'm Dr. John Torous. I've been speaking with Dr. McIntyre about GLP-1 receptor agonist mortality and cardiovascular outcomes in serious mental illness. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at JAMA Network. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.